into group 1 and group 2, and later on into group A and group B. And the third category which has been added recently is carry malformation. And in the congenital anomaly, we have various anomalies like os-odontoideum and os-terminale. However, this is a debated topic whether os-odontoideum is a congenital anomaly or the etiology is traumatic. So other pathologies which affect the craniovertebral junction is trauma. Like this trauma include atlas fracture. It can involve a rotator fracture or a hangman fracture, which is a fracture listhesis of C2 over C3. And there are various kinds of tumor which can also involve the craniovertebral junction. So talking about the surgical approaches to the craniovertebral junctions has been divided broadly into anterior and the posterior approaches. I will go one by one. In the anterior approach, we have microscopic transoral odontodectomy, which was used for the cases of severe basilar invagination. And the recent techniques which are in vogue nowadays are a submandibular retropharyngeal approach to the anterior C1, C2 joint and anterior fixation. And since the endoscopy has already entered our neurosurgical field, so endoscopic transnasal as well as transoral approach has also entered in this field of neurosurgical procedures. I will be talking about all these approaches in detail in my coming slides. So in the posterior approaches, as my sir told, there were techniques in which wiring techniques which were introduced by Galley, Brooks and Jenkins, Sontag, and then the lasso technique, which were initially used for the fixation of the C1, C2 junction. And but the important caveat of these techniques were we needed an intact posterior C1 arch and a posterior C2 bone, which are required. And there was significant compromise of the rotational stability in case of wiring techniques. So later on, the technique which was introduced by Magriel was transarticular screw fixation, which is still considered gold standard by many neurosurgeons, and it can be supplemented by wiring techniques further. In the other posterior approaches, we have techniques of Goel and Lahiri, which includes lateral mass screw in the C1 and involving plate and screw fixation and C2 pedicle screw fixation. And then talking about Harm's technique, the Harm's technique involves insertion of the pedicle screws, polyaxial pedicle screws, that is rod and cantilever mechanism. And the other techniques are laminar screws, which is basically a Wright's technique. And the technique other is which was introduced by Professor Saroj Chandra was DCER, extraction, compression, extension, and reduction for severe cases of basilar invagination. So now let's talk about the anterior approaches. In the anterior approaches, as we say, initially severe cases of basilar invagination were dealt with by the technique of microscopic transoral odontectomy to decompress the craniovertebral junction, to decompress the cervicomedullary junction, and later on, because it leads to destabilization of the craniovertebral junction, we also have to stabilize the CVJ by posterior approach, into which can involve occipitocervical fusion or occipitocervical fusion. And the endoscopic approaches, we have endoscopic transnasal approach. And other techniques in the anterior approach include anterior odontoid screw fixation, which is for type 2 odontoid fractures. And as I mentioned earlier, it's some mandibular retropharyngeal approach, which was introduced, which was started, but by our Indian surgeon, Dr. Spatkar. Submandibular retropharyngeal approach. First, anterior C1, C2 fixation. So as we all know, atlantoaxial dislocation is diagnosed on the basis of atlantodental interval. This atlantodental interval is usually less than 3 mm in adults, but in children it can reach up to 5 mm, and these are the limits which are considered normal. Anything above that limit is considered abnormal, and this shows that the joint is not stable. So, in the microscopic transoral approach, after induction of the anesthesia, the soft palate and the uvula was retracted by taking sutures or by the help of the nasopharyngeal tube. And then the nasopharynx, after injecting local anesthesia in the nasopharyngeal wall, the ventral arch of the C1 and the C2s are palpated. And then an incision is taken after palpating the C1 ventral arch, which extends 2 centimeters above the C1 ventral arch, and the lower limit of the incision extends to 2 centimeters below the C1 arch. The Sontag retractor system was utilized for this approach. So in the macroscopic transoral odontoectomy, this is the view we see. This is like upside down view. This is body of the odontoid. This is anterior arch of the C1, and this is the tip of the dens. So after the inferior part of the C1 ventral arch is removed, you can see this such kind of pathology is there that can be removed, like fibrosis and especially in cases of rheumatoid arthritis and other connective tissue diseases. And then the dens can be excised, and here we come across the cord. So by the anterior approach, that was the approach used for decompression of the cervicomedullary junction. And later on, the patient, because it leads to there, because many ligaments like apical ligaments, which are attached to the dens tip, this technique involves dissection of the ligaments. So we need further stabilization of the craniovertebral junction by the posterior approach. So this was considered a safe zone for the resection, because as the vertebral artery lies 1.5 centimeter away from the midline. So on either side of the midline, 3 centimeter bone area could be resected. And usually the superior part of the anterior arch was left because that served as a guide for the posterior fixation. Now, as I mentioned, the other anterior approaches involve endoscopic transnasal surgical technique, which are used by few surgeons for pathology of the craniovertebral junctions. And these pathologies involve usually like clival chordoma, basilar invagination, and foramen magnum tumor also, like foramen magnum meningioma. They can also be approached through the endoscopic transnasal methods. So in this method, if you are using this endoscopic transnasal surgical technique, the area which can be assessed is, it includes the area which extends from the plantar sphenoidal, and the caudal limit is decided by a line which is called a nasopalatine line. The nasopalatine line extends from the lower part of the nasal spine. It touches the posterior end of the heart palate and is extended posteriorly. So it extends and touches the C2 lower C2 body. So this is the lower limit of lesion which can be assessed through the endoscopic transnasal surgical technique. So as we have been utilizing endonasal technique for the excision of the pituitary tumor, these are the anatomic landmarks which you usually see in case of transsphenoidal resection of the tumor, and we all are, I think, familiar with this. So we have to create a nasoseptal fold, and then sphenoidal by adequana is identified, and we enter the sphenoethmoid recess, and sphenoid ostium is identified, and after that sphenoid rostrum is identified. So after resection the sphenoid rostrum, a wide sphenoidotomy is created so that we landscape view of the inferior cellular region and clival region. So this is the anatomy which we come across after a wide sphenoidotomy. This we can see the cellular area, and this is the clival recess. This clival recess usually correspond to the middle part of the clivus. And here you can see these are the clival clinoidal segment of the ICA, and these are the optic nerves before removal of the bone, and this is the left and the right opticocapillary recess. So after removal of the bone, we can see this is the anatomy we see. This is the clinoidal segment of the ICS, and this is the clival recess, and this is floor of the sphenoid sinus correspond to the lower part of the clivus. So this is the further illustration of the anatomy which we come across in the transnasal route. And after removal of the fascia, and the removal of the mucosal and the muscle flap, which involve longus capitis muscles in the upper clivus and the longus coli muscle in the lower clivus, we come across this kind of bony anatomy. in which we can see this is the lower part of the clivus. This is fibrosis anterior to the odontoid, and this is anterior arc of the C1. So this is a schematic diagram which see the pathologies and the area which you can visualize by the transnasal route, and it involves the C2 tip, C1 ventral arch. So this is the real-time images in which we can see the after the midline after the retraction of the nasopalatal folds, nasopharyngeal fold bilaterally, we come across the clivus and the C1 anterior arch like this, and slowly the ventral arch of the C1 is drilled. And then periodontoid fibrosis can be dealt with, as we find in many cases of bacillar imagination. And further, after that, we can remove the dents. That's the way we can decompress the cervicomedullary junction by the endoscopic endoscopic approach. So what is the advantage of endoscopic intranasal approach is that in case of the microscopic transoral approaches, we have the high incidence of velopalatine insufficiency. The patient had to be put on the RALS tube feeding for around 5 to 7 days. But in this endoscopic intranasal approaches, the risk of velopalatine insufficiency is less, though there is a risk of CSF leak, which can be dealt with by creation of the Haddard flap or the nasoseptal flap. So anterior approaches are also used for the other pathologies like the odontoid fracture. As we all know, the Anderson and the Diolonge, they classified odontoid fracture under 3 types, depending on the morphology of the fracture. But this was the type 1 fracture, which involves the tip of the odontoid. This is usually considered a stable fracture, and if they are managed conservatively. And this we can see is the type 2 fracture, which involves the dense fracture at the junction, and this is type 3 fracture, which involves a part of the body as well. So the type 2 fracture, this because of the precarious blood supply around this region, they are usually considered as unstable fractures, and they usually need surgical interventions. So in the anterior approach, anterior odontoid screw are used to stabilize this kind of fracture, and this is in which the incision is and the approach is the same as the ACDF. The incision is taken around C5, then the creation of the plane between carotid cyst and tracheoesophagus medially. We create a trough at the C2, C3 disc space, and then a guide after reduction of the fracture. A guide initial step is definitely reduction of the fracture, and that is mandatory for this approach. And then a K-wire is drilled through the fracture line and followed by placement of a lag screw. So this should be the ideal trajectory. A bicortical purchase should be aimed for to completely immobilize the fracture, and this leads to a proper union. The contraindication in case of anterior odontoid disc fracture is injury of the transverse atlantar ligament. If the transverse atlantar ligament is injured on the MRI, then we should not approach this method. The other relative contraindications include lack of alignment of the fracture preoperatively, and poor bone quality. Because if you have a poor bone quality, then the chances of pseudounion and failure of the implant will be high. Now, this is a new technique which I found very interesting. It may not be a new technique, but this is quite often being published and promoted by Dr. Sushil Patkar. That is anterior extrapharyngeal approach for the anterior C1, C2 fixation. So the important limitation of this technique is that the C2, C3 disc space angle of the mandible, as we can see on this lateral cervical spine images, it should be above the C2, C3 disc space. On the extension view and the extension and lateral view, if this angle of the mandible is not above the C2, C3 disc space, then we should not approach this technique. So this is the gross anatomy in which you can see the incision taken is a submandibular approach. The patient head in this position, first, if you're talking about position, the head is turned towards the opposite side, left side, and it is held in extension. Then a submandibular incision is taken, platysma is divided, and then we can identify the submandibular gland and the digastric tendon. Later, the digastric tendon is mobilized, and then we can come at, then we'll meet at, with the hypoglossal nerve, which can be retracted cranially, and then a plane we get between the carotid cyst laterally and the tracheoesophagus or pharynx medially. So this is a video which I had come across, which is very explanatory in case of this approach, which is self-explanatory how these pathologies are dealt with. So basically, as per Dr. Sushil Patkar, the in case of if you are approaching atlaternal dislocation by the posterior route, there is a significant risk of injury to the vertebral artery, whether we are doing a transarticular screw fixation or we are doing a rod and cantilever technique. So he says in case of anterior approach, the risk of injury to the vertebral artery is less as compared to the very less as compared to the posterior approach. And it also preserves the posterior tension band. So can you see the video, sir? This is a cadaveric dissection technique, step by step, in which, as I said, after platysma is divided, submandibular bone and the hypoglossal nerve is retracted. I had used this technique for the fixation of the hangman fracture, and we need some kind of surgical instruments, especially 80 mm long right angle retractors. They help in retraction. And sometimes, yes, angle of the mandible should be judged preoperatively. This technique works on the Wage principle. This technique also involves opening of the C1 C2 joint anteriorly, the gardening and the removal of the cartilage at the C1 C2 joint, and the placement of face set retractor and screws. So screws are passed in the lateral mass of the C1, and the trajectory for the C2 screw is medially and caudally. So these are the implants which are being used. So if you are able to perform this surgery, I mean, this technique, this is also a very good technique for the fixation of the C1 C2 joint, reduction of the bacillar invagination, and dealing with the problems of atlantic dislocation. So now I'll come to the posterior techniques in the surgical approaches. First, I will talk about the wiring, and the initial wiring technique was introduced by Galley. So it's a Galley fusion in which we can see the brief requisite, as I told earlier, is that we should have an intact posterior elements of the C1 or a C2 axis. Suppose if you are not having this posterior arch of the C1, then as introduced by Dr. V.K. Jain sir, we can create an artificial arch in the occiput, and that can be used for the wiring. And I have seen him doing, and I have assisted him by doing this. So it involves passing up a sublaminar wire below the C1, and then it is looped below the C2 sinus process, followed by placement of the graft and stabilization. The important caveat, as I told, is the posterior elements should are must for performance of this wiring techniques, and the rotational stability is not good in the wiring techniques. The other wiring technique was introduced by Brooks and Jenkins, which involved passing up two titanium cables in the sublaminar fashion at the C2 C1 joint, followed by placement of the weight separate graft to stabilize the cervical spine. They're still utilized in the pediatric population, and they're important rescue technique, I will say, in winning nowadays scenario to stabilize the craniovertebral junction. Then came the Magrill transarticular screw fixation. This technique is still considered gold standard, and it significantly increases the rotational stability. The important the result of this transarticular screw fixation is very good, and we can achieve a high fusion rate of around 86 to 100%. So in the transarticular screw fixation, as we talked about, the position of the patient is taken over, patient is taken over the three Mayfield head holder, and the position is military tuck position. I mean, it is the chin is flexed and the head is pulled dorsally. Then, as you know, incision is taken from the ineo to the C3 location, and the C1, C2 is exposed, and followed by we trace the joint. The joint has to be opened, the cartilage has to be curated, and the bone graft harvested from the anterior superior iliac spine or the posterior superior iliac spine can be stopped inside the joint is placed. So the alignment of C1C2 joint is must before starting the fusion procedure, and it usually involves taking stab incisions in the lower cervical at the cervical thoracic junction to start the procedure. So basically, the entry point for the screw is usually 2 to 3 lateral and 2 to 3 rostral to the medial aspect of the C2C3 facet joint. So we follow the direction of the pars, and then the facet of the C1 facet of the C1 is also first. We aim towards the anterior tubercle of the C1. It can be supplemented with wiring techniques. If we have posterior elements intact, and this almost achieves 100% fusion rates. The problem with this technique is that we have vertebral artery anomalies in many cases of axial dislocation as well as and basilar invagination, in which there is medial looping of the vertebral artery, or the vertebral artery comes in the path of the screw, or a high riding vertebral artery, which can be judged on the basis of the preoperative imaging, like preoperative CT scan and pre-CT angiography of the neck vessels. So that there are roughly 20% cases in which this cross-articular screw fixation cannot be achieved. But recently, I had been to a conference in Mumbai and we were talking about this technique in which we knew I came to know that if we have a diameter of around 2.7 left in the pars, because we have two diameter screw, 2.7 and the 3.5 screw. Still, if we have a 2.7 screw with 2.7 diameter pars left, we can go for this Magwell technique. So this is how the trajectory looks like. If the entry point is 2 to 3 superior and lateral to the medial aspect of the C2C3 facet joint, it follows the pars, it crosses the joint and enter the C1 arch. So now we'll talk about C1C2 rod and cantilever technique. First, I'll talk about our Indian centers like Goyal and Lahiri. They introduced lateral mass plate and screw fixation system, which involves, again, the patient is placed in the prone position over the horseshoe and traction is applied. For the entry point of the incision and the dissection part is same. The C1 lateral mass and the C1C2 joint is exposed following the pars. I usually follow the pars and expose the C1C2 joints. Then we will come across the C1C2. Then we come across the C2 ganglion, which can be detected inferiorly to get over the axis of the entry point for the C1. So the entry point for the C1 in case of this Goyal and Lahiri technique is 1 to 2 over the C1C2 joint center, and the direction C1C2 joint over at the center of the C1 lateral mass, and the direction of the screw is 10 to 15 degree medial and cranial. For the entry point of C2, in the Goyal's technique, we have he had explained that the pars should be divided to like 9 quadrants. These are the 9 quadrants. And I have myself seen him. He utilizes the superior and the medial quadrant for the insertion of the pedicle screw. So basically, Goyal and Lahiri technique includes C1 lateral mass and C1 pedicle screw. As I was reading in residency about the craniovertebral junction, there is a lot of confusion regarding the isthmus pars and the pedicle screws. And after reading through a lot of literature, I came to know about how is the pedicle, what is the pedicle entry point, and what is the pars entry point. So by the Goyal technique, he uses this superior medial quadrant. After dividing the pars into the 9 quadrants, he utilizes the C2 superior and the medial quadrant for the insertion of the C2 pedicle screw. So his constructs look like this. The C1 screws, they are directed, they are inserted in as usual classical fashion, which is, which I said, 1 to 2 above the entry point is 1 to 2 above the C1C2 joint, and it is directed cranially and the medially. And the C2 screw is superior and the medial quadrant introduced. So as this the entry point in the C2 screw is cranial and medial, so the risk of the vertebral artery injury is less. So we have other options also for insertion of the C2 screws. Because C2 screw, there is always a significant risk of injury to the vertebral artery. So on the left side, as you can see, this is the inferior facet screw. So the screw is inserted in the inferior facet of C2. And on the right side, you can see the screw is inserted in a transarticular fashion, which is crossing the inferior facet of the C2 and entering the C3 laterals. So coming to the Harms technique, in Harms technique also is the entry point for the C1. C1 remains same. That is after exposure of the C1 C2 joint. In every technique, it's mandatory to curate the C1 C2 joint, garden the joints, and stop bone graft, which we have harvested from the anterior cervical leg spine or the C2 spinous process itself, and that is very important for the fusion. But the entry point for the C2 screw in case of Harms technique is different. He basically divides this parts into four quadrants and then he utilizes this cranial and the medial quadrants for the screw insertion, and the trajectory is usually 25 to 40 degree, 25 to 50 degree cranial and medially in case of C2 pedicle. So this is also a technique of C1 lateral mass and C2 pedicle, because it enters through the pedicle and goes enter through the pedicle, goes into the body of the C2. So what I have also used in other my surgeries is, and there are different kinds of C2 screws which are available, like short pass screws, long pass screws, transarticular screws, pedicle screws, inferior facet screws, and inferior facet with transfacetal screws. So for the short pass screw is also a very safer option, in which the entry point is same as that of the transarticular screw, which is very 2 to 3 mm above and lateral to the medial aspect of the C2 C3 joint, and the screw length is usually 40 to 60 mm. In while using the C2 facet C2 short pass screw, the advantage I have noticed is we get a fulcrum effect, and other is the risk of injury to vertebral artery is very less as compared to the pedicle screws. This is how the clusters looks like in case of C1 and C2 fixation by the Harms technique. So this is another technique which biomechanically is considered as equivalent to PARS, in which we involve insertion of the polyaxial screw at the spinal laminar junction in crisscross fashion. And this can be technique. This technique can be used when you have thin pedicles, and we don't want to take this. So still, I consider occipital-cervical fixation we require many times in a case if you find that the vertebral artery course is very anomalous and we don't have a poor quality bone. We have thin pedicles in the C2, then occipital-cervical fixation can be utilized. This is safe and very effective. So I will discuss about a few cases which I had done. So my first case was a 53-year-old male who had presented with the neck pain relating to the suboccipital region, and he used to say that he noticed some sounds, clicking sounds on necking movement. He had a history of jerk. He had a history of jerk to the neck while carrying heavy load overhead, and after stumbling on uneven surface on your back. So neurologically, he was luckily intact, but he had a significant atlantoaxial dislocation. So my way of going is I do always NCCT flexion extension, that is NCCT dynamic NCCT flexion extensions to look for atlantodental interval in case of flexion how much it is, and in case of extension how much. So here we can see the ADI in case of flexion was 9.87 mm, and in extension it was 9.4 mm. So it was like irreducible AD, but I have noticed that the so-called irreducible AD or the imaging, most of the times they can be reduced after joint manipulation. So this is the post-op image in which I had this was fixed with the posterior approach, in which I had opened the C1 C2 joint. Again, the same method, the curettage of the joint and filling of the joint with the bone grafts, and then I usually manipulate the C2. And after removing the tension band, the important point here is that C2 spinous process can be nibbled and the posterior tension band has to be released. So by manipulation of the joint and the manipulation of the C2 spinous process, I find it that most of the cases, in most of my cases, I can reduce the atlantoaxial dislocation. So this was the post-op image. Here we can see the atlantodental interval had reduced from 9.8 9.4 mm to 2.6 mm. So this is the screw which are used. I had used the C1 lateral pass screw with the bicortical purpose, but I had told I had used this short pass screw, and I could get a. These are the post-op images. My second patient was a 21-year-old male who had presented with a severe spastic paralysis, and he was wheelchair bound. So on imaging on the MRI and the CT scan, we can see he had a osodontodia with the high cervical myelopathy. These are the pre-op images, which very well explain the clinical picture. So these are the post-op images. Again, I had supplemented in this case because the joints, when I opened the joints, I saw it was quite rounded. So I had drilled the joint surface, I had stopped bone, but still I supplemented this patient with the posterior wiring technique also. So I didn't do any decompression. I had just done a C1 lateral mass and a C2 passes to fixation with the posterior supplementation by the wiring technique and placement of the bone graft between the C1 C2 C1 lateral C1 posterior arch and the C2 spinous process. And he improved significantly, and at least he can walk independently by now. So, thank you. This was, I know this topic is very wide, and we can go on, keep on discussing about this, but this was a kind of short topic. Anyway, I said
thank you very much. Thank you very much, Dr. Rohit, for enlightening us about the surgical approaches. These are, I think, new, very new for neurologists like us. We always wonder how neurosurgeons do these surgeries. So I have only one single question to you, Rohit. Day before yesterday, I had a small child, 10-year-old child, who came to me with torticollis. On examination, he had a short neck, some low hairline, and mild restriction of movement. No other neurological deficit was there. On MRI, he had basilar invagination, narrowing of foramen magnum, as well as some stretching of cord. So, what we should offer to this kid? He's 8-year-old child. Just have only torticollis.
Sir, he had torticollis, but if you see, because the low lying hairline and the short neck, they all point towards the clipal film.
Would you like to advise surgery to him, or just immobilization?
Sir will like to advise surgery to him because though he is neurologically intact right now, but sometimes even a trivial trauma can lead to quadriplegic paralysis and involvement of the respiratory muscles as well. So my approach is I advise them that though you are neurologically intact and you can walk, you are independent, but this trivial trauma, once I was discussing this kind of thing with the Dr. B.K. Jain sir also, so he told me you would have heard that in a classroom a teacher had put a teacher slapped a student and he fell down and he couldn't get up and he landed up in a ventilator. So that's the kind of scenario we can get in case of young boys. Then the trivial trauma can lead to catastrophic neurological deficit, which can lead to further complications. So I will advise to, with given risk, definitely we have risk in C1 C2 fixation, but I will advise fixation.
What is best age for surgery? Can it be done in a child?
Sir, a 10-year child can be done, sir, in the pediatric population. I don't have much experience, but in a pediatric population also, we have enough bone in the lateral mass of the C1 and the C2, where we can get away with posterior C1 C2 fixation. And for the reduction of the BI, we can put spacer as well.
Don't this surgery hamper in development of this CB junction?
Sir, CB junction,
because CB junction, the ossification center has not fused till this age.
Sir, up 10 years of age, I think it is fused.
Okay, 10 years, it fused by 10 years.
Yes, sir, it is.
So in pediatric population, the child was 8-year-old. So we should wait for.
Sir, in the pediatric population, as I told you, we can see in his leaving the unstable craniovertebral junction is never advisable because even the trivial trauma, as I said, can lead to catastrophic complications. So
yes, definitely.
So other methods like wiring techniques we can use, and we can use reef graft for stabilization in case of the pediatric population. But I had a discussion with a pediatric neurosurgeon on this topic, and he said that most of the time we get enough of lateral mass and C2 bone and we can go ahead with the instrumentation. So, but in my opinion, I think we should stabilize if we have.
Dr. Arvind,
the risk of complication in case of pediatric population is higher as compared to the adult population. Risk of implant failure is mainly usually higher.
So you have nicely discussed about various surgical approaches. I would request our chairpersons to have their comments.
Yes. So,
Thank you, Rohit, for a wonderful presentation. And I think now very less of these transoral surgery are being done. I think in our time the transoral odontectomy was a rule, was a routine surgery. But now most of these can be avoided by the posterior approach. If you are putting a spacer or you are doing screws. So transoral odontectomy is nowadays a very uncommon surgery which is being done. In anterior approach, I think the odontite screw is very common nowadays. If you have fresh odontite fracture type 2, so odontite anterior odontite screw is a beautiful procedure. It gives excellent results and it gives excellent stabilization also. For posterior fusion also, I think wiring is almost now outdated. Now no one is doing nowadays a Gillies or a Brooks approach, and most of the new generation, I think, who are now this is part of their training, and they are doing C1 lateral mass and C2, depending on the, like, what is the condition. There's sometimes C2. Suppose you are not very well versed with the procedure, you can even go for the laminar screws. They are also very good. So if you are not very comfortable with putting a C2 pedicle screw or a pars screw, you can put a translaminar screw, and they also give a good strength. So I think you have covered most of the things. And absence of C2 posterior, C1 posterior arch is not absolute contraindication. You can create artificial posterior arch of the C1 by drilling the part of the occiput. So we have covered most of the part, most of the surgery. I just wanted to know how many of us or how many of you are doing submandibular approach for the C1 C2 stabilization.
Sir, for C1 C2 stabilization, I have not done for submandibular approach, but I had done a submandibular.
I have seen some presentation by Sushil Patkar, but I have not seen any other person presenting their work on a submandibular approach for C1 C2.
Sir, many neurosurgeons in the Pune, I think they are doing, who have worked with Dr. Sushil Patkar, sir. I had done a submandibular approach for a hangman fracture for a C2 C3 anterior cervical discectomy infusion, ACDF.
Okay.
So ACDF C2 C3 up to level I have done, but maybe in the future I may try this technique because now I am familiar with anatomy. So I'll go ahead. But yes, the important caveat is that important lateral cervical spine X-ray should have been done, and the angle of mandible should be above. If the angle of mandible is below or at the level of C2 C3 disc space, then we cannot reach that space.
Yeah. I think
if you have to do C2, C3 anterior, if there is a anterior discectomy infusion, you have to go by submandibular.
Yes.
There is none other approach than it. And sir, it's not very difficult. It's just you have got just orientation for it.
Orientation, and I think the long retractors are needed, like 80 mm with blades. Though they're prerequisite, I had got those made for me when I had done the
get
surgery.
A good extension.
Exactly. Then neck length should be good.
Yeah. As Mahesh sir has rightly said, most of the CVJ, even the baseline invagination, are dealt mostly by posteriorly. The point is we have to do a comprehensive joint drilling. The pathology is a C1 C2 joint. As I am trained in PGI Chandigarh, so they do a comprehensive joint drilling. They just make the joint flat and then put a spacer with a good bone graft taking bone from the ribs, and then tighten the screw and with a cantilever technique, roll off the dense, roll the anterior, the atlas posteriorly, so it becomes just in the alignment. Even I have done number of cases right over here, and as told by Dr. Arvind sir, even in kids, as per my experience, I am doing a lot of CVJ over here. Yes. Even in kids, we used to do a atlas wiring.
Yes.
In 3 years old kid to get a fusion of C1 C2. Yes. The pathology is C1 C2. We are not fusing all of the joint, so it does not hamper the growth of all the subaxial spine. Only the C1 C2 is hampered. That's okay, but we want to fuse it. If there is a baseline invagination, we have to treat it. We can't keep it as a watchful measure.
Okay. Ankur, Anand this side. And
Anand
just
Boss.
one question, जो Dr. Arvind ने पूछा था question कि if the patient is asymptomatic and only presents with torticollis and he has an irreducible AD, do you still want to go ahead with surgery?
No, it's not a irreducible, it's a BI.
It's a baseline imagination.
It's a
Wait,
baseline type
imagination
osteoporosis.
with
It's a
narrowing
type
of
I
osteoporosis.
agree. If the patient has torticollis and an irreducible AD without BI, do you still think that a surgery should be done in that case?
No, without BI, and it's a irreducible AD, then we can watch. Then it's all
So-
about the joint pathology.
Hmm.
Even Anand Boss will agree. Even in some of the kids, joint are very malformed. We are unable to get the C2 screw or C1 even. So we have to do a occipital and long posterior fusion.
Yeah, I completely agree with you, Uncle, but I just have this doubt whether only BI, if the patient has only BI and torticollis, whether they want to go ahead with a full-blown surgery or not. No, I think the opinion would be divided. I think Mahesh Boss is here. He might.
I think
Uh,
we can just observe and see. You have to see so many. You have to see MRI picture of the how much kinking is there. What
Yes,
is the
exactly, sir.
possibilities? So there's so many things which you have to consider because clinical is such a common. This is one of the commonest anomaly, and I think you have to observe. But most of them may require surgery in days to
Yes, sir. I completely agree. Sir, if the patient goes on to develop any deficit, then
Yeah.
surgery is 100% yes. Otherwise, a 10-year-old child, it might be a bit iffy to go ahead with surgery. You can go ahead with it is not a contraindication, but you can still, I think you might be able to wait and watch for any deficit to occur because it is an only BI, and BI usually accompanies not not a reducible AD, but an irreducible AD. Usually, BI accompanies an fixed AD. In that case, you might actually wait because in this case, if the patient has torticollis, the patient might have severe joint deformity or joint malalignment. In that case, surgery also becomes very tricky in this case. If the symptom is only torticollis.
see.
Uh,
Any other comment?
Anand
Any
sir,
other
what should be the cause of the torticollis?
Ankur, bhai, that is what I am saying. If the patient has torticollis with BI, the only possibility is that the patient has some joint abnormality.
Yes.
है ना? So joint asymmetry, that actually makes the surgery much more tougher. So you can do, I'm not saying it is done, it should not be done. It can still be done. But it might be tricky. You have to talk in the patient and then you might take up the patient for surgery, or the other option might be you can actually observe the patient if he goes on to develop any symptom. Because you might, I mean, even in your experience, you might have seen 20, 30-year-old patients coming to you with torticollis or with BI and their patient is relatively asymptomatic.
Yes, sir, I fully agree with you.
I think Guru, we cannot make it a rule. You have to see individual cases, I think. But obviously, these cases has to be watched. If I'm in a bad practice, obviously I will, unless the patient is symptomatic, I'm not going to use my knife. Obviously, that's something. You being an academic institution, you can have those things. But unless a patient asks for surgery or demands a surgery, like neurologically he has a deficit, just for torticollis, I'm afraid of. At least I'm not going to do that. Observe patient, see how much, what is the magnitude of baseline imagination, how much kinking of cord is there, what is the ADs, and there's so many things. Normally they have a block vertebra down, below down also, C3, C4, C5. So we only treat the patient is really, or is a progressive deficit. Patient is coming to you with a progressive deficit, then you go and intervene.
Yes, sir.
Young child.
I think once neurological involvement starts, then there is a definite indication for surgery.
Yes, then it is 100% surgery. You have to do surgery. Then there is no option. Secondly, what Mahesh sir said, I just want to add on to that. Sometimes the patient has associated anomalies. For instance, if the patient has BI, he might also have Chiari malformation. In that case, you might have to need surgery for Chiari, and because you're doing surgery for Chiari, then you can
Then
do
you do.
fixation simultaneously. So there are many factors that have to be taken into consideration. As Ankur rightly pointed out, that many of these patients would actually be having abnormal joints, and that is usually the pathology, underlying pathology that patient has torticollis. So many things have to be seen. The CT, CBJ has to be seen, the MRI has to be seen, and then you can make a decision along with the patient's parents.
Definitely. So, any other questions from audience?
Doctor,
Sir,
Dr. Arvind, I would like to have your
yes,
comments.
sir. Listen, first of all, sir, I would like to correct you. I'm still an assistant professor, and I have a senior Dr. Suyash Singh who is running the department. Thanks for inviting me here, and I am doing CBJ, and I went to learn from Professor Goyal himself, and I will speak what he has to say for a few cases. Like first of all, the child you mentioned about, because the child is himself the picture you described. It is the picture itself is taking us to the CBJ, and then the patient is having torticollis. But as you say, sir, because child's age is 8 years and there was no AAD, and we are always afraid that yeah, definitely a small trauma can cause him to go on ventilator. We are definitely want to put the child on Philadelphia, and then we can always assess that if possible we should go for the surgery. That fusing the joint is the one thing we want right now, so that he doesn't this torticollis and the alignment doesn't deteriorate. Otherwise, later on he can develop scoliosis and all. Second thing, sir, the transoral approach I wanted to say already obsolete. We are not doing, because BI, if it is there, we can always open up the joint and always put some amount of bone or spacers are there. I'm putting almost 5 to 6 spacers, and they are very good in reducing BI. And whatever part where we are not able to reduce, we are always doing a 1 centimeter of foramen magnum decompression, and that serves the purpose for us. Then third thing I want to mention, sir, I always prefer to go for pedicle screw, because they are the one which are very robust construct. And Professor Salunke also always say in his presentations that as near as joint we fix the joint, our fusion rates are always better. So that's why I usually prefer, and as his paper also says, I will go for a C1 lateral mass screw and a C2 pedicle screw wherever it is possible. And the screw length should also be not too long, so that the fusion should be at nearest to the joint, and the tulip should be resting on the lateral mass of the C1 and the C2 pedicle screw. So what we can do here in patient is of AD, there is always difficulty of putting the rods. So people are saying, like, if you are using a short length screw in C1, how you put a rod? So there is one screw developed by Professor Deepak Singh, and that is a reduction screw we can always use, and it's very good in these kind of circumstances where we can always reduce the joint and use a shorter screw, and there is very robust and very good construct we can get in the end. So, and obviously, as Dr. Rohit has mentioned, and he has elaborately discussed everything about the all type of C2 screws. Definitely, if the C2 pedicle screw is not possible due to somehow, always there are some relative contraindications, like the joint has been crossed by the vertebral artery, or we are not able to purchase a very thin pedicle. We always have a fear of going into vertebral foramen. Then we can always opt for a pass screw or a C2 a transficit screw. So with this, just I want to thank Dr. Rohit and for this presentation, and all my senior consultants. I'm very young in this field and still learning. And I thank Dr. Kankani to inviting me and in considering me to be a part of being a chairman. Thank you. Thank you very much.
I'll have you speaker also. Just be ready.
Sir, thank you, sir.
I invite you for speaking on this platform in coming months.
Thank you very much. Thank you very much, sir.
Invite you.
I'm
So
honored.
be prepared with some very good topic, which is useful for everyone.
So,
Definitely.
sir, again, I would say KC2 pedicle is definitely the best purchase we get. I am doing pedicle screws. Recently, I had done for a case of C1, C2, 3 OPLL, which was extending from the foramen magnum from the occipitocervical junction to the C3 level, in which we had to fix the C1, C2, C3 because we had to decompress the C2 because the mass of OPLL is right behind the body of the C2. And definitely, wherever possible, we should go for C2 pedicle screw, which has a very good purchase. And I preferably use Harm's technique for the placement of the pedicle screw as compared to the Gold's technique. Even I have used Gold's technique in my residency days. But I prefer Harm's technique because we are using a screw and the polyaxial screws and the rods.
So, any other comment from anyone? So I think this nice presentation by Dr. Rohit Pandey. He has given a lot of insight about the CV junction surgeries, and it is, I think, going to be useful for each and everyone, or neurologist as well as neurosurgeon. I would like to extend my sincere thanks to Dr. Rohit Pandey, who has presented
you,
here
sir.
on this Zoom platform. I would like to thank both of our chairpersons, Dr. Arvind Kumar and Dr. Mahesh Kodyal, for conducting this today's activity. And I would like to thank all our viewers who are here with me, or everyone who is connected with YouTube channel also. Lot of persons are seeing YouTube channel also, sir. So thank you everyone for being with us.
Thank you, dear.
Thank you very much.
Thank you,
Thank you,
sir.
sir.
Thank you,
Thank
sir,
you, sir.
for this
sir.
great
Thank you.
initiative you have
Thank
taken.
you very much.
Thank you, sir.
Thank you, sir.
Hats off to you, sir. Thank you.
Sir, we may leave now.
Yes.
Okay,
Thank
thank
you.
you, sir.
अच्छा अरविंद सर,
हाँ
वो इस बार का इनकम टैक्स भरना था, वो भर
हाँ
गया है।
हाँ हाँ
और जो पुराना अकाउंट का था ना सर,
हाँ
तो अकाउंट का दिक्कत थी, तो इस
हाँ
बार आनंद बॉस करा रहे हैं यहाँ पे एलजीपीजीआई में,
हाँ
यूके न्यूरोकॉन अपनी।
हाँ